Sounds sounds good. Good morning, everybody. I am Dr. Himanshu Deshwal. I'm an assistant professor in the Division of Pulmonary Critical Care Medicine at WVU, and I'm a part of the Pulmonary Hypertension Clinic here. So, as the topic today is going to be about pulmonary hypertension and how to just very basics of it and how to approach and manage patients with pulmonary hypertension. I'm pretty sure if you take care of patients with chronic lung diseases or any kind of lung disease, a lot of times you may come across patients with pulmonary hypertension, and it's a complex disease to understand. So we will try to get into the basics of it and at least give you a sort of a refresher on it so that you can assess and at least decide on how to pursue management and diagnostic evaluation for these patients. So today I have no conflict of interest or disclosures for this particular presentation. And the objectives will be to understand pathophysiology of pulmonary hypertension and its classification, approach to diagnostic evaluation for PH, and then updates in the management of pulmonary hypertension. And just to start with, let's talk about these two cases. And I'm pretty sure like you may have seen something similar in your practice or in your clinical setting. So patient one is a 65-year-old with chronic comorbidities like diabetes, hypertension, atrial fibrillation, comes in with shortness of breath and leg edema. Echo does show normal ejection fraction, but grade 3 diastolic dysfunction, so left-sided disease, with some mildly dilated left atrium. The RV size is mildly increased and RV function is normal, but the pulmonary artery systolic pressure, or RVSP, is around 60 millimeters of mercury. Now, in patient two, also 61-year-old female with hypertension, hyperlipidemia, but has scleroderma and has similar presentation of shortness of breath and leg swelling. Nearly normal ejection fraction with mild diastolic dysfunction, normal left atrial side, but severely dilated right ventricle, right ventricular dysfunction, and PSP or RVSP of 76 millimeters. So the question to you is, are these patients the same? Or do they have the same type of pulmonary hypertension, or something else is going on and they need to be evaluated further to see what is going on and how you will treat it, because treatment differs significantly in these patients. So let's start talking about understanding pathophysiology of pulmonary hypertension and its classification. So if I was to put pulmonary hypertension in one slide, it's basically pulmonary vasculopathy or arterial remodeling that leads to basically increased pulmonary vascular resistance, and increased pulmonary vascular resistance ultimately leads to right ventricular failure. So on an MRI, this is what normal right ventricle would look like, smaller than the left ventricle. In pulmonary hypertension, you will see that the right ventricle is just dilated and very, very significantly abnormal compared to the left ventricle. So it's a disease of the right ventricle, and it's a disease of the pulmonary vasculature. And if we were to talk about the pathophysiology of untreated pulmonary hypertension, this is what it would look like, at least based on the echocardiogram. So you would have a patient who has continued pulmonary vasculopathy that's leading to increased pulmonary artery pressures. RV up to some point will adapt to those pressures. And there is a common saying that, the function of the right ventricle is significantly dependent on the left ventricular septum. So 80% of the right ventricular function actually comes from the left ventricle. And when the pressures go up, it's able to accommodate that pressure and it maintains the stroke volume. So these patients may be asymptomatic in the beginning and they might not demonstrate features of heart failure. But when the pressure continues to go up, you will start having some right ventricular hypertrophy, some dilation of the right atrium, but you will still maintain the functionality of the right ventricle to PA coupling, as we call it, and the stroke volume will still be maintained, which means that they will still not have significant symptoms, but may start having some shortness of breath. Now, if you leave it untreated, you will have worsening symptoms. You will have increased risk of supraventricular tachycardias because the atria starts dilating, and you might have SVTs, AFib, other things like that. And then you might have more features of right ventricular failure like leg swelling, congestive hepatopathy, cardiorenal AKI, etc. And if this goes untreated, then the right ventricle cannot hypertrophy any further, so it starts dilating. Then it starts pushing the septum towards the left ventricle. This is where you lose the septal contribution to the right ventricular function, and you start going into this phase of profound RV failure. And eventually, there is so much congestion that you start having pericardial effusion because of the myocardial veins getting congested, and you start having pericardial effusion, your cardiac output starts dropping, and then you go into cardiogenic shock. So, hemodynamically, as time progresses, pulmonary vascular resistance continues to increase because of vasculopathy. Your pulmonary artery pressure will go up, but at some point it will start going down because the right ventricle just cannot tolerate high pressures. So, in advanced stages, the pulmonary artery pressures may actually be low. And then your cardiac output also starts going down, which at the end of the stage, you will see normal or mildly elevated pulmonary artery pressure, severely reduced cardiac output, and very high pulmonary vascular resistance, which basically demonstrates end-stage pulmonary hypertension. So why is this important? So there were some studies that, especially in the VA population, that they looked at, and they found that 20% of the US population has echo evidence of pulmonary hypertension. Now, it doesn't mean that all of them have group 1 pulmonary arterial hypertension where the vessels are damaged. It's some sort of pulmonary hypertension, and we're going to talk about what those some sorts are. And when they divided them into tertiles based on how much the pressures were high, you can see that the patients who had higher pressure, say 34 to 66, had worse mortality compared to patients that had lower pressures. And it was similarly in patients who did not have any cardiopulmonary disease. So it goes on to say that the higher the pulmonary artery pressures or higher RVSP on echo, higher the mortality. So it is important, regardless of the cause of pulmonary hypertension, that higher the pressures are associated with increased mortality. And the goal in these patients is to find basically Waldo. So everybody on echo will have pulmonary hypertension if they have some kind of a cardiovascular or pulmonary disease. But the goal is to find Waldo who has pulmonary arterial hypertension or PAH. The rest of them will have some heart failure or COPD or interstitial lung disease or bad sleep apnea with obstructive obesity hypoventilation syndrome. Maybe they'll have CTEPH, which is chronic thromboembolic pulmonary hypertension, or group 5, which is unclear mechanism. So that's how the current guidelines classify pulmonary hypertension. So the first one is group 1, which is basically idiopathic or heritable, and then associated conditions. So HIV, connective tissue disorders, unrepaired congenital heart disease, meth-induced or drug-induced pulmonary hypertension. It's extremely rare, and this is the group 1 PH that has very bad survival, and you really need to diagnose them early so we can treat them and actually improve their survival significantly. There are more than 14 medicines approved for this disease, and we see these patients all the time in our ICUs that are coming in decompensated because of a misdiagnosis, but we're still able to revive them and give them a normal life for a long, long time. So it's no more, gone are the days when somebody had pulmonary hypertension diagnosis and nothing could be done about it. It's a disease that you cannot cure it, but you can treat it. Then the most common pulmonary hypertension is group 2, which is due to left heart disease. So you have bad mitral valve stenosis or mitral valve regurgitation, bad aortic stenosis, heart failure with reduced ejection fraction or bad HFpEF. Those are the patients that will have pulmonary hypertension due to left heart disease. So classic patients will be anywhere between 40 to 80 years old, obese, diabetes, hypertension, AFib. Those are the patients that have the classic stigmata of group 2 disease. Then the second most common that we see, especially in West Virginia, is the group 3 pulmonary hypertension due to chronic lung disease. So somebody with very advanced COPD, somebody with interstitial lung disease, somebody with untreated sleep apnea with obesity hypoventilation syndrome, with their CO2 being in the 70s, high altitude. So those are all associated with group 3 pulmonary hypertension. Then you have group 4, which is again rare. This is due to somebody who has chronic pulmonary embolisms or other pulmonary obstructions from sarcoma, etc. This is the only form of pulmonary hypertension that is curable. So this is why we need to evaluate all patients with pulmonary hypertension with a VQ scan to rule out chronic clots, because they can be surgically removed and that can cure pulmonary hypertension in these patients. And then group 5 is anything other than the first 4 groups. So these are pH from unclear or multifactorial mechanisms. So sarcoid-associated pulmonary hypertension, somebody with renal failure, somebody with myeloproliferative disorders. Those all come in group 5 disorders. Now, what are the challenges? So the studies have shown that, on an average, when a patient starts having symptoms, it almost takes 2 years to first consider a diagnosis of pulmonary hypertension from symptom onset to diagnosis, which is pretty sad. So you can see the current status is 27 months of symptomatology before somebody starts thinking about pulmonary hypertension. 1 in 5 patients will never get diagnosed with pulmonary hypertension. They'll just die without ever receiving a diagnosis. And you can see that this is a study that was done in New Zealand, where they found that it took almost an average of 5 visits to the primary care, almost 3 visits to a subspecialist, that means a cardiologist or a pulmonologist, before they could consider a diagnosis of pulmonary hypertension. If they had a comorbidity of COPD or sleep apnea, the diagnosis of pulmonary hypertension was delayed. The reason being is they thought this is all contributed from sleep apnea and COPD and then just ignored. And then just to make matters worse, this was a study from Journal of American Heart Association. So this is a very interesting study. What they did was they created these simulated patients, and they sent out the survey to pulmonologists and cardiologists across the country, in community settings, in private practice, in academic settings, everywhere. And they gave them these virtual patients where they had like suspicion of PH or no PH, and saw how a cardiologist or a pulmonologist would approach them. And you can see that the diagnostic accuracy of us, that is the specialist in pulmonary and cardiovascular diseases, was 46%. So 50% or 54% of the times you were getting a diagnosis wrong. Pulmonologist was most likely to make a PH diagnosis, not significantly different from the cardiologist, but were equally like to make an incorrect diagnosis of PH when they did not have PH. So this tells a lot about the current status of how misunderstood or misdiagnosed pulmonary hypertension is, and hence this talk today, to just enlighten a little bit about this disease and sensitize what we can do to diagnose this. So what are the symptoms and history findings that you may notice? So if somebody's having dyspnea that cannot be explained with their underlying disease, so somebody has mild COPD, but they can barely do their activities. Somebody who's having extreme fatigue and having symptoms of syncope or presyncope, that's a very, very severe sign you should consider for pulmonary hypertension. If they do not have other causes or neurologic, severe mitral stenosis or aortic stenosis, if that's not there, then you should really think that could pulmonary hypertension be present. Cough and cough can be present in some of these patients, especially when your right atrium dilates. It can irritate your phrenic nerves and your cough reflexes that can cause cough. And then palpitation from SVTs, as we talked about, these patients are at increased risk of arrhythmias. On examination, you will hear a mild systolic murmur. You might have a loud P2 or a split S2 sound. And then they may have orthostatic hypertension. And that's very interesting, because what happens is when you do positional changes, the preload to the right ventricle changes. So when you have, when you go from standing to supine position, there's more preload to the right ventricle. It pushes the septum to the left ventricle, reducing left ventricular filling, and hence reduce cardiac output, and hence reduce blood pressure. So this may almost mimic as if somebody is dehydrated, but it's actually because the RV is so full that it's compressing on the left ventricle. So orthostatic hypertension could be a sign of pulmonary hypertension if they have gross hypervolemia, like leg swelling and other things on exam. And then they might have hepatomegaly, elevated jugulovenous distension, ascites, and edema, which can easily be misdiagnosed as cirrhosis, but is actually from chronic RV failure and congestion of organs downstream. So how do you approach it? So the first thing is, if somebody comes in with shortness of breath, you evaluate them for a few basic things: an X-ray, maybe an EKG, an echocardiogram, a pulmonary function test. Those are your basic tests that you do for anybody with shortness of breath. So what are the findings of pulmonary hypertension or arterial hypertension? So you will see what we call prominent P waves, which may suggest RA dilation or our right-sided disease. You might have a right axis deviation in 1N AVF. You might see RV hypertrophy and RV strain, where you have ST depressions in the anterior leads. So these are the signs that may suggest maybe there is something going on with the right ventricle. We should figure out whether this is because of pulmonary hypertension. On an X-ray, the lungs would look clear, but you will have prominent hyla with prominent pulmonary vasculature. On lateral views, you might see a prominent right ventricular enlargement that might reduce the retrosternal space because of the RA and RV dilation and the shift of the heart laterally. On an echocardiogram, of course, we always talk about this RVSP. So let's talk about what RVSP is, or right ventricular systolic pressure, how it's measured, and what are the caveats, because sometimes you might have somebody who has no RVSP mentioned but has like really bad pulmonary hypertension. So essentially what they do is in a 4-chamber view, they put color Doppler across the tricuspid valve. And in this video, you can see there's this white colored jet that goes through. So all of us have a little bit of tricuspid regurgitation. When you have right ventricular dilation or right ventricular dysfunction from pulmonary hypertension, this regurgitation gets worse. And essentially what you do is you put a continuous Doppler across it, and it spits out basically a number that you can measure like a jet, and that is what we call the tricuspid regurgitation velocity. And then using the Bernoulli's equation, you can do 4V square, where V is your tricuspid velocity, and that gives you a pressure. So if your tricuspid velocity is 4, then the pressures are 4 times 4 square. So 16 times 4, that's 64 millimeters of mercury. So that's how they measure pulmonary hypertension, basically. And the problem is that it's very variable and it's very inaccurate. And in fact, a study looked at it and showed that patients who had same-day right heart cath found that 32% of these patients had overestimations on echo, 29% had underestimation of echo, and only 40% correlated with the right heart cath. And somebody who had an echocardiogram within the 1 month of right heart cath, you can see 43% were overestimated. So they were overcalled, and 25% were underestimated, which tells us that echo is not the end all or be all of diagnosis of pulmonary hypertension. You cannot start anybody on therapy just based on echo, and it can be very inaccurate. So what are the other signs on echocardiogram that should make you worry about pulmonary hypertension? What if the echo report doesn't have RVSP? So the things to look at would be dilated right atrium, dilated right ventricle, septal flattening because of pressure overload, pericardial effusion. So if you see all these things, that should make you worry that something is wrong with the right ventricle. We don't know what it is. And it could be pulmonary hypertension, especially in a patient who's passing out, who's having profound shortness of breath, and you can't explain why. So this is the diagnostic algorithm that we usually follow, and this is based on the guidelines. If somebody comes in with unexplained symptoms of shortness of breath and suspicion for pulmonary hypertension, you do a thorough medical exam to look for risk factors, like are they doing methamphetamine? Do they have history of HIV or scleroderma? Do they have any family history of pulmonary hypertension? You do basic workup. You look at their oxygen saturations. You look at a brain natriuretic peptide because it will be elevated both in heart failure and pulmonary hypertension. You can get an EKG to look at right-sided disease like right axis deviation, RV hypertrophy. And then you get an echocardiogram if you're worried about pulmonary hypertension. Now, based on the echocardiogram, you can decide whether to pursue guideline-based workup of pulmonary hypertension to rule out causes. And basically what that will show is whether they don't have pulmonary hypertension, so echo is normal, then you have to think about other causes of shortness of breath, or they have low pretest probability, so they have no risk factors for pulmonary hypertension, the echo is normal, then you can think about other causes and then treat them accordingly. If it is intermediate, so RV is dilated, but you don't have an RVSP, or RVSP is severely high, and then you have a dilated right ventricle, then that gives you intermediate to high probability. In those cases, you can do either a rapid referral to pulmonary hypertension or refer them for right heart cath, but you also have to get all these tests. And the reason why we do these tests is to make sure we get the correct diagnosis. So for example, once the echo shows concern for pulmonary hypertension, you have to get a VQ scan, which is more sensitive than a CT angio for chronic clots. And this test has to be done in all patients of pulmonary hypertension. The reason being is it will detect if there is presence of chronic clots or chronic thromboembolic disease. And it is the only curable form of pulmonary hypertension because surgically you can just remove those clots by doing pulmonary thromboendarterectomy, and they can be cured of pulmonary hypertension. And then, of course, like, you may get a CT angio to see if there is an acute pulmonary embolism. You can see where the location of these clots are. That can help you decide whether surgical treatment is available. The same CT scan will also rule out chronic lung disease. So if they have pulmonary fibrosis, bad COPD, or something else going on with the lungs, that may explain the severity of pulmonary hypertension. And then pulmonary function test. So if they have severe restriction or obstruction, that means there is maybe chronic lung disease that's causing or contributing to pulmonary hypertension. And then there are certain serologic workup like brain natriuretic peptide, autoimmune conditions. So most classic one is centromere antibody, which is related with limited scleroderma, limited cutaneous scleroderma, that is associated with pulmonary hypertension, rheumatoid arthritis, HIV. And then if they have history of alcoholism or NASH cirrhosis, doing a portal Doppler ultrasound to rule out portal hypertension, because that can also cause portal pulmonary hypertension. So that is another hidden cause that we often forget to work up. So this is how basically you do the workup for pulmonary hypertension. But during any of this phase, so from diagnosis, from suspicion to diagnosis, you can refer these patients to a pulmonary hypertension specialist anytime you think that this needs to be done quickly. And the point is you have to do it quickly. Because if they're presenting to you with shortness of breath, they're already very advanced in their disease. And you know that the median survival in these patients is 2.7 years. And then time to diagnosis is almost 2.5 years. So they don't have a lot of time left if they're coming with decompensated right ventricular failure. So it won't be like 6 months or 1 year later they're seeing a specialist. By that time, they won't be alive. So you have to, like, if you suspect pulmonary hypertension, send them in, get them evaluated ASAP so they can at least start treatment and reverse some of the disease that can prolong some life. And then eventually the diagnosis is set by right heart catheterization. So we have a state-of-the-art cath lab here where we can even do exercise right heart cath if resting numbers are negative, but the diagnosis, the concern for pulmonary hypertension remains high. And then the numbers we usually measure is the right atrial pressure, right ventricular pressures, pulmonary artery pressure, and pulmonary artery wedge pressure, which is a marker of left ventricular and diastolic pressure or left atrial pressures, to see if there's a contribution from left heart disease. And then we do some calculations to figure out what's going on. And this is how we hemodynamically differentiate different types of pulmonary hypertension. So any mean PA pressure more than 20 millimeters of mercury is a diagnosis of pulmonary hypertension. Now, based on the right heart cath, we have to decide whether this is pre-capillary. That means that problem is in the capillaries or the pulmonary artery. So all your pulmonary hypertensions from group 1, group 3, group 4, group 5 will fall into pre-capillary disease. If you have a left heart problem, so say a mitral valve disease or an aortic valve disease, it'll cause back pressure into the pulmonary veins, and that will cause high wedge pressure. So if you have a wedge pressure more than 15, that's your pulmonary hypertension due to left heart disease. And then in rare circumstances, you may have where your wedge is normal and your pulmonary vascular resistance is normal. These are patients who have high flow. So somebody with AV fistula, somebody with hyperthyroidism, somebody with anemia will have just high flow state. So they will have mean PA pressure more than 20, but their left heart is normal, so their wedge pressure is normal. Their capillaries are normal, so their PVR is normal. So this is a very rare, but happens. Like I've had referrals where a patient was on levothyroxine for hypothyroidism, but for some reason, the primary care practitioner was very, very fixated on getting that TSH number lower. And in that setting, the patient started having AFib, echo started showing high mean PA pressures. So we basically told them to reduce the dose of levothyroxine, and the RV pressures normalized 3 months down the line. So these are the things that you can consider in those patients. Now, there is something else we do when we do right heart cath. We expose them to nitric oxide. So you may have seen some cath reports where they say non-vasoreactor or did not respond to nitric oxide or Flolan on the vasodilator challenge. So essentially, the reason for this test is purely to see if the patient will qualify for calcium channel blockers. So if you are vasoreactive, which is 1 to 2 patients in a million, so it's an extremely rare form of pulmonary hypertension where they will react to nitric oxide or Flolan, where their pressures will go down. And these patients benefit significantly from calcium channel blockers like amlodipine, diltiazem, verapamil. But rest of the patients, if they don't respond, are not a candidate for calcium channel blockers, and then you need to start them on other pH therapies that we'll talk about. So not everybody who has pulmonary hypertension should be given calcium channel blockers, because they can actually make things worse. It's only for patients who are vasoreactive. And the definition of vasoreactive is somebody's mean PA pressure dropping more than 10 and dropping below 40 with or without increase in cardiac output. So if somebody had a mean PA pressure of 55 and we challenge them with nitric oxide and it drops to 35, that's a vasoreactor. If somebody was 42 and dropped to 38, that's not a vasoreactor. So in those patients, you bypass the calcium channel blockers and you go straight to pH-specific therapies that we will talk about later. Once the right heart cath is done, then you need to assess what was the cause. So, you've done all the workup. Now you stratify, is it all heart failure? Is it all COPD, or is it group 1 pulmonary hypertension? You assess severity. So the patient's in RV failure, the right ventricle looks horrible on the echocardiogram. And then there are certain scores that you can use. So MD Calc has all these scores available that can put them into low, intermediate, or high risk category. And the importance of this is that you can see if the patients are in high risk category, you can see the survival is only 43% at 5 years. But if they are in low risk category, the survival is 96% at 5 years. And the goal is, so the treatment goal for pulmonary hypertension is to get these high risk patients into low risk category. So once you start treating these patients who are diagnosed and have high risk status based on the scores, and you treat them and you get them into low risk status, their survival improves to 96% at 5 years. And we have patients who've been on therapies for 20, 25 years living a normal life because they were diagnosed and treated early and aggressively to get them into this low risk status. And these are the scores that we talked about. There's a Reveal 2.0 risk score. You can easily find it on MD-Cal. And then there are these European scores that we often use as well. Okay. Now, what are the updates in the management once we've diagnosed pulmonary hypertension? So the goal is to improve survival, improve quality of life and functional status, improve their hemodynamics on right heart cath, improve their risk scores. And of course, these therapies have a lot of side effects, so managing side effects. In addition to that, you do supportive therapy, so diuretics, oxygen. Sometimes if they have bad AFib, in addition, you might do digoxin, anticoagulation if they have pulmonary embolism. General measures, pulmonary rehab, you have to do a psychosocial support because it's a terrible disease to have. Immunization becomes very important because infections can precipitate pulmonary hypertension exacerbation. And the most important thing is family planning. So we know that especially young women who are planning family, childbirth or pregnancy is very high risk in pulmonary hypertension, and mortality reaches almost 40 to 45% in these patients. So you have to have at least two forms of contraception in patients with pulmonary hypertension, and surrogacy and other things may be an option. Or we can consider this in high-risk patients once you get them to lower status and have a multidisciplinary high-risk OB-GYN involved and then consider it. But usually the recommendation has been to avoid pregnancy in all possible ways if you have a diagnosis of pulmonary hypertension because the mortality is just extremely, extremely high. So what are the targets and therapies for pulmonary hypertension? So basically, the three major pathways, the nitric oxide pathway, the endothelin pathway, and the prostacyclin. So the nitric oxide and prostacyclins are basically vasodilators that cause vasodilation in the pulmonary vasculature, and that's how pulmonary vasculature is so compliant. So if you have reduced levels of nitric oxide or reduced level of prostacyclins, you'll have vasoconstriction and pulmonary hypertension. Endothelin, on the other hand, is a potent vasoconstrictor. So overactivity of endothelin also causes pulmonary hypertension. So the drugs basically are endothelin receptor antagonists. These are your bosentan, ambrisentan, macitentan that block endothelin, causing vasodilation. Then you have the nitric oxide pathway, which is your PDE5 inhibitors, sildenafil and tadalafil, and the soluble guanylyl cyclase simulator like riociguat. They work on the nitric oxide pathway. And then you have the prostacyclin pathway. So epoprostenol, prostanol or Flolan, treprostinil, iloprost, and then selexipag or Uptravi, which is an agonist of the prostacyclin pathway that causes vasodilation and some remodeling in the pulmonary hypertension. And then we have this latest medicine that is called sotatercept, which basically binds on the TGF-beta superfamily that actually works higher up in the pathway and prevents remodeling of the pulmonary vasculature. And studies are showing that it has a significant improvement in pulmonary hypertension outcomes in these patients. So this is a new medicine that was just FDA approved, and we started using it with dramatic results in these patients. So treatment approach is once you have confirmed diagnosis, if they have significant cardiopulmonary comorbidities, somebody with obesity, diabetes, hypertension, then you try it with monotherapy. So you'll start them on sildenafil or tadalafil and then add another drug if they're doing good. If they have no comorbidity, so scleroderma patient, 45-year-old female or male with scleroderma, bad pulmonary hypertension, you categorize them into low risk, intermediate risk, or high risk. If they're low risk, you'd start combination therapy with tadalafil or sildenafil with endothelin receptor antagonist like bosentan and macitentan. If they're high risk, you directly jump to parenteral prostacyclins like Flolan or epoprostenol or treprostinil in the IV or sub-Q form. And then you follow them very closely, 6 to 8 weeks, and re-stratify them in scores based on their functional status and other things. If they come in the low risk status, you continue the current treatment. If they are in intermediate risk, you add more medications. If they are in high risk, you add parenteral prostacyclin or refer them for transplant. And the same thing applies for patients with cardiopulmonary comorbidity. So you start them basically on 1 or 2 pills, and you add the third pill. If they are high risk, you directly jump to parenteral therapies. Again, there is a lot of caveats to it. Like somebody who's living alone, has no social support, you're not going to put them on a pump with parenteral prostacyclins because they won't be able to manage it. If it dysfunctions, they can die. So that you have to consider oral therapies and try to work around it and get them managed appropriately. So what is the future? So there are, as I talked about, the sotatercept. This is the newer medication that just got approved. The STELLAR trial showed remarkable improvement. Patients who were already on like 3 maximum medications and were still not doing well, when they added sotatercept, they saw a significant improvement in 6-minute walk test and reduction in the time to clinical worsening. There is another drug in the pipeline called seralutinib, which was confirmed on TORREY trial to be beneficial with reduction in pulmonary vascular resistance. So these are these are drugs that may, change the way we treat pulmonary hypertension. So these drugs are being touted as anti-remodeling drugs. So they might partially reverse the disease, not only treat it, it might reverse the disease. So there are so many options for these patients that we can give them and get them better. So this brings us back to the case. So both patients underwent pulmonary hypertension evaluation. The first patient had high mean PA pressure, confirming pulmonary hypertension, but also had high wedge and normal pulmonary vascular resistance, suggesting that they had pulmonary hypertension due to heart failure. So they were treated for heart failure. The second patient had scleroderma, where the pulmonary vascular resistance was very high and the wedge was normal, suggesting this was group 1 pulmonary hypertension, and they were treated with pulmonary hypertension meds. And the reason why this is important doing the right heart cath is if you treated the first patient with PH therapy, they can go into pulmonary edema and have worse survival because you will dilate the pulmonary arteries, and back pressure of, might cause more pulmonary edema and actually make these patients worse. So that's why doing a right heart cath when you suspect pulmonary hypertension is important. So you don't treat patients that don't benefit from PH therapy, but also not miss patients who have pulmonary hypertension and you treat them. So conclusion, pulmonary hypertension as a whole is very common. Group 1 pulmonary hypertension is rare, but it's often missed. It's that Waldo that we often miss, and it can be deadly. So making the diagnosis early is helpful. Knowing the clues for pulmonary hypertension in a dyspneic patient is important. So look at the EKG, look at the chest imaging, look at echocardiogram, look at the history. And then if RVSP is not given in an echocardiogram, look at other things like dilated right ventricle. Is there septal flattening with RV pressure overload or volume overload? And then if you really want to diagnose somebody with pulmonary hypertension, right heart cath is required by gold standard to differentiate the type of pulmonary hypertension. And then timely referral and collaboration with PH centers improve survival in these patients. With that, I will conclude. This is our pulmonary hypertension team at WVU Ruby Hospital, led by Dr. Sharma, who's also our division chair. And then we have Cassandra, and Barbara has been, she basically retired. So we have Krista, who's taken over. And then we do have an annual symposium, John Parker Symposium, every year, where we talk about different pulmonary related diseases. So you're most welcome to join, and you can find more detail online on this. Thank you. So if you have any questions, please feel free to ask.